It doesn't say it on my end.
Okay, it says starting recording. Kay is recording the call. All right, we're good, right? Just make sure it's recording so that your classmate can watch this afterwards on our YouTube page. All right, welcome, term 5. So let's begin. Pharmacology, side effects in a nutshell. So you need to know antihistamine, antiadrenergic, and antimuscarinic. Antihistamine, think sedation, weight gain. Antiadrenergic, hypotension. Antimuscarinic, dry mouth, blurred vision, urinary retention, and constipation. Commonly seen in what medications? Antidepressants and your low potency antipsychotics. Question: how can we differentiate serotonin syndrome with neuroleptic malignant syndrome? Anyone? What's the difference between serotonin syndrome and neuroleptic malignant syndrome? Which one has myoclonus? You can jump in on the call.
Serotonin syndrome.
Excellent. Which one has increase in creatinine kinase?
NMS.
Neuroleptic malignant syndrome. Which one has lead pipe rigidity?
NMS.
Neuroleptic, excellent. NMS. So those are the differentiating factors. Serotonin syndrome, commonly seen when you combine your SSRIs or paroxetine, fluoxetine with monoamine oxidase inhibitors, your MAOs, your give me an example of a MAO inhibitor. Phenylcypramine, right?
Linezolid.
It can be. Treatment, you stop the medication and supportive care. Hypertensive crisis can be seen when you are taking MAO inhibitors, but then you eat theremin-rich food. Let's go back to term 1. What's the treatment for hypertensive crisis? Alpha antagonist. What is it?
Phentolamine.
Phentolamine.
Phentolamine. Excellent. Why phentolamine? Because it's a reversible alpha antagonist. So EPS, Parkinsonism, akathisia, dystonia. Parkinsonism, think mask-like face. They have a cog-wheel rigidity and bradykinesia. Commonly, you can see pill rolling tremor. Akathisia just means restlessness. They need to move. They can't sit still, and agitation. Dystonia is a sustained, painful contraction of the muscles of the neck, tongue, eyes, and diaphragm. Don't forget in the vignette, oculogyric crisis. So their eyes move upwards, like that. Question: the first-line treatment of extrapyramidal symptoms caused by antipsychotics is what? What is the first-line treatment for EPS caused by antipsychotics?
Benzos.
Benzo what? Benzodiazepines?
Benztropine.
Excellent. Benztropine. Don't forget that. That's your cogentin. So the EPS is most commonly seen in typical first-generation antipsychotics, so Haldol, your flufenazine. It is reversible. It occurs within hours to days of starting meds or increasing the doses. In rare cases, guys, it can be life-threatening. Now, we need to keep the term kinesia, right, straight. What do we mean by acute dystonia? Acute dystonia, it is characterized by twisting and abnormal postures. Contrast that one with akathisia, which is characterized by what? Inability to sit still. Contrast that with bradykinesia, which is characterized by what? Decreased or slow body movement. Contrast that one with tardive dyskinesia. What is this? Characterized by grimacing and tongue protrusion. So you need to know that your kinesias. Let's summarize. Tardive dyskinesia, think in the vignette, grimacing and tongue protrusion. Acute dystonia, characterized by twisting and abnormal postures, akathisia, inability to sit still, and bradykinesia. Congratulations to Tom Brady, by the way. It's characterized by decreased or slow body movement. We're good so far? We're good so far?
Yes.
Yep. Okay. Next, about the side effects. So I'm just pulling out the major side effects, and we're gonna go on deeply within each class of your your psychiatric drugs. Okay. Hyperprolactinemia. So this occurs with your first generation antipsychotics, fluphenazine, and Risperdal, your risperidone. Tardive dyskinesia. You have a chorioathetoid muscle movements. Chorioathetoid meaning like a snake-like movement of the mouth and tongue. It can affect the extremities as well. It occurs after years of your antipsychotics with high potency first generation. And unfortunately, guys, it is irreversible, even if you give valbenazine, okay? Treatment for tardive dyskinesia. NMS, as I've said, think mental status changes, elevated creatinine, phosphokinase, and lead pipe rigidity. Those are your buzzwords. It's a medical emergency. Why? Because it has a 20% mortality rate. Another question for you guys. What is the most common side effect of your anticholinergic medications? What is the most common side effect of anticholinergic?
Urinary retention.
Again, please.
Dry mouth and urinary retention.
Yes, but the caveat here is the most common. Constipation, okay? That's it. Constipation is the most common side effect of your anticholinergic medications. Can you give a patient who has dementia an anticholinergic medication? Is there a danger in giving someone who has dementia an anticholinergic medication? Yes or no?
Yes.
Yes. Why? Because?
I think I know it can worsen the effects, but I'm not sure.
Exactly. Excellent. That's it. It can exacerbate the neurocognitive disorder. The patient has already dementia and you're giving anticholinergic medications and you're having like hypotension and all of this bad stuff. So it can actually exacerbate the dementia. Another high yield. Don't forget drug interactions. They love this one, even on the step. Your sip inducers, right? What are they? Tobacco, carbamazepine, barbiturates, St. John's wort, and CYP inhibitors, fluvoxamine, fluoxetine, paroxetine, duloxetine, sertraline. Okay? All right. That's just a summary. Let's go one by one. So major depressive disorder. Let's go back to term 2. So this is you have, what's the DSM-5 criteria? One major depressive episode, no history of manic or hypomanic episodes. In terms of epidemiology, onset at any age, no ethnic or socioeconomic differences. Depression can increase mortality for patients with other comorbidities. You can have sleep problems associated with MDD. Hypersomnia is less common, so they are hyposomnic. REM, sleep is shifted earlier in the night, so decreased REM latency for a greater duration. You have reduced 3 and 4 of your slow wave sleep. In terms of etiology, MDD is most likely caused by neurotransmitter abnormalities in the brain. So what are those? Evidenced by the following. So when you give antidepressants, there is an increase in your catecholamines. You have a decreased CSF of 5-HIAA, which is the main metabolite of your serotonin. This has been found in your depressed patients with impulsive and suicidal behavior. So MDD, neurotransmitter abnormalities. There's something wrong. And what can be found in the CSF? Low levels of 5-HIAA, which is the main metabolite of your serotonin. What else? They have increased sensitivity of beta adrenergic receptors in the brain. High yield depressed patients, they have high cortisol. Why? They have hyperactivity of your HPA axis by failure to suppress your cortisol level in the dexamethasone suppression test. They also have an abnormal thyroid axis. So thyroid disorders are associated with your depressive symptoms. Some research suggests that GABA, glutamate, and others play a role. If you have multiple adverse childhood experiences, they are a major risk factor for later developing MDD, some child abuse, sexual abuse. That. In terms of genetics, first-degree relatives are 2 to 4 times more likely to have MDD. And the concordance ratio is like 40% for monozygotic. For dizygotic, it's 10 to 20%. What's the prognosis? What's the course and prognosis of MDD? It is very self-limiting, right? However, what's the risk here? If someone is depressed, they might take their own life, right? So they're much more prone to suicide. Now let's talk about antidepressants. So the major categories that you should know: Ssri, heterocyclics, specifically TSA, and your tetracyclics, MAOIs, and miscellaneous antidepressants. All antidepressants have similar response rates in treating major depression. Question for you guys. Patients should receive an adequate trial of antidepressants for how many weeks before you consider changing the medication? What's the minimum?
6, I believe.
Excellent, good job. So they should receive an adequate trial of, for example, SSRI. Then at least 6 weeks. If it doesn't work, change it to another SSRI or change it to an SNRI. Okay? Approximately 60 to 70% of the patients with major depression will respond to an antidepressants medication. So there's only like 30% that doesn't respond to the medication that they're taking. So most antidepressants, they require a trial of 3 to 4 weeks for an effect. Some people requiring as little as 1 to 2 weeks, some 6 to 8 weeks. Don't forget, antidepressants have a withdrawal phenomenon. So in the vignette, if they say there's dizziness, headaches, nausea, insomnia, and malaise, you need to taper down the antidepressants. So because they're much tolerable to the patients, because of safety, SSRIs and others, they have become the most common agents used to treat major depression. However, guys, the choice of a particular medication for a given patient should be made based on what? The symptoms, previous treatment response by the patient or a family member. Usually, if the family member responds well to paroxetine, then the patient will probably respond well to paroxetine. Side effect profile, of course, comorbid conditions, risk of suicide by overdose on the medication, and last but not the least, of course, the cost. Now, let's look at the specific categories of antidepressants. SSRI. What's the mechanism of action of SSRI? High yield. They inhibit the presynaptic serotonin pump that take up serotonin. So what? Thereby increasing the availability of serotonin in your synaptic cleft. They also cause downstream effects, increasing brain plasticity. However, this mechanism has been hypothesized to delay the onset of antidepressants effect. So don't forget, guys, drugs that increase serotonin may be found in over-the-counter what? Give me an example. Drugs that increase serotonin may be found in over-the-counter what? That can possibly lead to serotonin syndrome.
Nasal decongestants.
Excellent. Your dextromethorphan fans, right? It can possibly cause serotonin syndrome. So based on their half-lives, most SSRIs can be dosed daily. Fluoxetine has a weekly dosing form. There is no correlation, however, between plasma levels and efficacy or side effects. So a patient comes into you and it says, Doc, I don't like the sexual side effects of SSRI. What can you do? What can you do?
You can give bupropion because they don't have any sexual dysfunction side effects.
Exactly. You can augment, I repeat the word, augment the regimen with bupropion. You're still going to give the SSRI. However, you augmented it with bupropion. What else? The first thing that you need to do, if clinically appropriate,
Lower
Doc,
dosage.
SSRI, it's killing me. I can't get it up with my wife.
Lower the dosage.
Excellent. Reduce the dose if clinically appropriate. So first lower the dose, and then what else? You can change to a non-SSRI antidepressant. And someone said it, you can augment the regimen with bupropion. And last but not the least, you can add a medication. What is that medication? The blue pill, sildenafil. You can add Viagra. Let's look at examples, right, of SSRI. So fluoxetine or Prozac, high yield, longest half-life. Therefore, no need to taper. High yield, safe in pregnancy. Common side effects, high yield, insomnia, anxiety, sexual dysfunction. But don't forget, it can elevate levels of antipsychotics, leading to increase in your side effects. How about Zoloft? Zoloft or sertraline, high yield, GI disturbance. The most common side effect is GI. Others, insomnia, anxiety, and sexual dysfunction. Paroxetine, Paxil, highly protein bound. High yield, the most common side effect, anticholinergic effects, and sexual dysfunction. This has the shortest half-life out of all of your SSRI, leading to withdrawal phenomenon if not taken consistently. Fluvoxamine, or your Luvox, commonly approved for OCD, right? It has multiple drug interactions. Citalopram is the fewest drug-drug interactions. However, it can increase your QT prolongation, right? And citalopram, this is like an enantiomer of your citalopram. Similar efficacy, however, fewer side effects. Also, dose-dependent QT prolongation. Most commonly seen in the clinic, fluoxetine, you should know that. Sertraline, you should know. Paroxetine, and citalopram. Question, guys. Do all SSRIs have a black box warning from the FDA? Yes or no? Yes, they have a black box warning. Why? Does anyone know? So a black box warning, it applies like to children and young adults to age 25. The FDA puts it there because of an increased risk of developing something. Do you know what it is?
Ideation.
Excellent, good job. So the FDA, it has a black box warning for all SSRIs, potentially increasing suicidal thinking and behavior, right? So don't forget that. How about the side effects for your SSRIs? Of course, they're tolerable. They have significant fewer side effects than your TCAs and MAOI. Much safer in safer in overdose, sorry. Many of the side effects are resolved within days. You have GI disturbance, insomnia, anorexia. However, the most important side effects are sexual dysfunction. 30 to 40% of your patients will gonna complain to you about that. Decrease in libido or sex drive, anorgasmia, they can't achieve orgasm. There's delayed ejaculation, right? This may occur weeks to months after taking an SSRI, and typically do not resolve. Restlessness also, and akathisia. like state. Also serotonin syndrome. Don't forget that. Serotonin syndrome is common when serotonergic drugs are used with MAOIs. Don't forget, SSRIs should not be used for at least 2 weeks. You need to have a washout period before or after the use of an MAOI. Because if there's no washout period between transitioning from SSRI to MAOI, you can have serotonin syndrome. Although hyponatremia is very rare, seizures, you have a 0.2% risk, slightly lower than your TCA. Let's look at miscellaneous antidepressants. SNRIs, venlafaxine, used for depression, high-yield GAD, generalized anxiety disorder, and neuropathic pain. Side effect profile similar to SSRI, with the exception of high-yield increase in blood pressure in all of your SNRIs. There's a new form, this venlafaxine. It is expensive and it has the same mechanism of action and the same efficacy as your venlafaxine. So what's the point of prescribing Pristin? Duloxetine is your Cymbalta, high-yield, used for people with depression, neuropathic pain, and fibromyalgia. Side effects similar to SSRIs, but more dry mouth and constipation. Beware of hepatotoxicity, so you need to get the liver function test before giving them Cymbalta. And of course, it's very expensive. Question, guys, for SSRIs, it can increase the level of a drug. Think about coagulation cascade. So SSRIs can increase the level of a drug that affecting a factor in your coagulation cascade. Can you tell me the name of the drug? It affects vitamin K epoxide reductase. What is the drug?
Warfarin.
Excellent.
Warfarin.
Good job. Good job. So SSRIs can increase the levels of your warfarin, requiring you then, doctors, to increase the monitoring when starting and stopping these medications. Another favorite of SGU, bupropion, your norepinephrine dopamine reuptake inhibitors. So high yield, lack of sexual side effects as compared to the SSRIs. However, beware. Why? It can lower the what? Bupropion can lower what?
The seizure threshold.
Exactly, seizure threshold. It's right over there on the slide, people. Side effects include increased anxiety as well as increased risk of seizures and psychosis at high doses. So, use with caution in patients with what and what?
Bulimia and anorexia.
Bulimia, anorexia, and what else? There's another one. Status epilepticus. Tonic-clonic. Grand mal, petit mal. What are those?
Seizures.
Epilepsy. So use with caution in patients with having seizures or epilepsy and eating disorders. Another SU favorite, trazodone and nefazodone. It is useful in treating major depression and insomnia. Why? It has a sedative effect, high yield. Don't forget that. They do not have side effects of SSRIs, and they do not affect your REM sleep, right? So that decreased REM latency in major depressive disorder, it's gone. That 3 and 4 wave phase changes, it's gone. Side effects include orthostatic hypotension, cardiac arrhythmias, they love this, priapism, right? Trazodone, and sedation. So trazodone causes priapism. Think trazodone will raise the bone. I know, it's tacky. Because of orthostatic hypotension in higher doses, trazodone is not frequently used solely as an antidepressant. So it is commonly used to treat insomnia, often when initiating an SSRI. Don't forget, nifazodone has a black box warning for serious liver failure and is rarely used. Let's talk about alpha-2, adrenergic receptor antagonist. There's only one that you need to know, mirtazapine, Remeron. Useful in treatment of high-yield major depression, especially in patients who have significant weight loss and/or insomnia. Side effects include sedation and weight gain. Question, guys. Remeron for treating major depression in what population is very helpful? Remeron for treating major depression in what age group? It's really helpful. Come again, please.
The elderly.
Excellent. Why? Look at the side effects and tell me why.
People with insomnia.
Yep, in the elderly. Why? Because it helps with their what? With their sleep, right? They can sleep really well, and appetite, right? Sometimes the elderly, they are cachectic. So mirtazapine, the major side effects, the sedation and weight gain. Basically, we're using the medication because of the side effect, okay? And don't forget, they have a fewer side effects compared to your SSRIs. Next, heterocyclic antidepressants. Do I need to know this? Yes, of course, specifically your TCA, tricyclics, tertiary amines. Don't forget, these are highly anticholinergic and antihistaminergic and antiadrenergic. Oh my God. HAM, anti-HAM, right? So amitriptyline, chronic pain, migraines, insomnia. Imipramine, useful in high-yield enuresis. What is enuresis, anyone?
Bedwetting.
Bedwetting, excellent. And panic disorder. Clomipramine, high-yield treatment of OCD. Doxepine, treating chronic pain. Secondary amines, however, there are less HAM side effects. Example, nortriptyline, high yield, least likely to cause orthostatic hypotension, useful in treating chronic pain, and desipramine, more activating and least sedating. It has the least anticholinergic of all of your secondary amines. Question, guys. The treatment for TCA overdose is what? High yield. The treatment for tricyclic antidepressant overdose is what?
Sodium bicarbonate.
Exactly. IM, IV, sub-Q. IV. IV sodium bicarbonate. Next. Tetracyclic antidepressant. If you have questions, put it in the chat. I'm gonna answer them after we finish this. We're gonna have a break later. Okay? Next, amoxipin. This is the metabolite of your loxapine. I haven't seen this one in my psychiatry rotation. It may cause EPS and has a similar side effect profile to your typical antipsychotic. Don't forget, guys, a 1-week supply of your TCA, as little as like 1 to 2 grams, it can be lethal in overdose. TCAs are highly protein bound. They are lipid soluble. Therefore, they can interact with other medications. They have antihistaminic properties, antiadrenergic, and antimuscarinic. The anti-HAM, don't forget that. Lethal in overdose. What are the signs and symptoms of overdose? Agitation, tremor, ataxia, arrhythmia, deadly, delirium, hypoventilation, CNS depression, right? Seizures, 0.4%, the risk, but it's still there. And serotonergic effects, erectile dysfunction in females and anorgasmia in females. Let's summarize. Major complications of TCAs. 3 Cs. 3 Cs. 1. Cardiotoxicity. 2. Convulsions. 3. Coma. Those are the major complications of your TCAs. Another question for you guys. Your monoamine inhibitors, they are more effective than your tricyclic in what kind of depression? Your monoamine inhibitors are considered more effective than your tricyclics in what kind of depression?
Atypical.
Atypical.
Excellent. Good job, guys. Give me the characteristics of an atypical depression. What are the characteristics? Go. Why is it called atypical? Because it's the opposite of MDD, right? So tell me the characteristics then. Go.
Wait.
Hypersomnia, right? It's the opposite of MDD. Think hypersomnia. What else? Increase in appetite. What else? They love this one. Heavy feeling in the extremities. They're gonna put in the vignette. Doctor, my feet feels like lead. They're very heavy. Okay? Heavy feeling in the extremities. And of course, increased sensitivity to interpersonal rejection, right? Oh my God, that's my Valentine's Day tomorrow. Don't forget that. Your features of your atypical depression. MAOIs, more effective than TCAs. All right. Let's talk about MAOIs. So they prevent the inactivation of your biogenic amines, such as your norepinephrine, serotonin, dopamine, and tyramine. Can someone just tell me the catecholamine synthesis and the enzymes involved? Term 1, let's go back. Can someone just tell me the catecholamine synthesis? How are we synthesizing norepinephrine and epinephrine? What is the precursor protein for this? Phenylalanine, right? Phenylalanine to what? Tyrosine, right? What's the enzyme? Where's my biochemistry?
Tyrosine decarboxylase.
Careful.
Hydroxylase.
Hydroxylase, right? And then from, oh, my memory is failing me. Tyrosine to L-DOPA. Tyrosine hydroxylase. L-DOPA to dopamine. DOPA, decarboxylase. Dopamine to norepinephrine. DOPA B hydroxylase. Norepinephrine to epinephrine.
Methyltransferase.
PNMT, excellent. What's the cofactor in there? Cofactor for the last one.
P6 now.
No.
Tetra.
SAM, S-adenosyl methyltransferase. How about the before that? Vitamin C, right? Okay. All right. So please make sure know that pathway. That's very high yield, the catecholamine pathway. We just glaze over that. So they bind irreversibly, right, to the enzymes MAO-A and MAO-B. So there are two MAOs. Can you imagine that in history if there were two MAOs? MAO-Is, they increase the number of your neurotransmitters available in synapses. Thank you for that, Labs. Somebody appreciated my joke. So MAO-A, preferentially, they deactivate your serotonin and norepinephrine. However, MAO-B, it preferentially deactivates your phenethylamine. So both types, they act on your dopamine and your tyramine. Is this the first-line agent? No. Why? Side effect profile. The patients generally do not tolerate this really well. However, high-yield MAO-Is are used for certain types of refractory depression. And you need to know the names. Phenelzine, tranylcypromine, and isocarboxazid. I have a question again for you guys. So just remember. It is a MAO inhibitor that used to treat depression that does not require following the dietary restrictions when used in low dosages. It is a MAO inhibitor that is used. Excellent, good job. Your MSAM. Selegiline is your MSAM transdermal patch, right? However, you should avoid what? Bonus points. Who can answer this? However, you still avoid. Come again?
L-DOPA.
Nope. However, you should still avoid what? Because it can precipitate serotonin syndrome. So you need to avoid decongestants. You need to avoid opiates. Example of opiates: meperidine, fentanyl, tramadol, right? And serotonergic drugs. Okay, that's just like a fun fact for you guys. Let's look at the side effects. Serotonin syndrome, when you combine SSRIs and MAOIs, they're taken together. What's the sign and symptom? They're going to describe it to you. Lethargy, restlessness. Don't care about that. Think about myoclonus. If myoclonus is there, it is serotonin syndrome. You can still have hyperthermia, hypertonicity, and rhabdo, but rhabdomyolysis is much more pronounced in your neuroleptic malignant syndrome. That's why you have an increase in your creatinine phosphokinase. Again, washout period. Wait at least 2 weeks before switching from your SSRI to MAOI. And we have the famous hypertensive crisis. This is the risk when MAOIs are taken with tyramine-rich food. Question for you guys before we move on to hypertensive crisis. First step when suspecting serotonin syndrome. What are you gonna do? Someone came in, doctor. This patient has serotonin syndrome. The nurse says, okay, this patient has serotonin syndrome. He has myoclonic jerks. He has hyperthermia, hypertonicity, all of those signs and symptoms. What are you gonna do when you suspect it? What are you gonna do? Doctor.
Ciprofloxacin.
It can be, yes, of course, it can be used. Serotonin antagonist, ciproheptadine, high yield, don't forget that. Or you could give supportive care. Even benzodiazepines, it can work. Okay, good. Hypertensive crisis, if you're taking MAOIs, don't take foods with tyramine. The good life, right? La Dolce Vita, red wine, cheese, chicken liver, foie gras, my favorite. Fava beans, cured meats, because it can cause a buildup of your stored catecholamines. So in addition to high blood pressure, you can also have sweating, nausea, vomiting, photophobia, and all of those. However, the most common side effect of your MAOIs are orthostatic hypotension. Drowsiness, weight gain, all of that, dry mouth. So for MAOIs, you start low and go slow. So low doses first, and then you increase it. Okay? I have a question again. Guys, you know the answer to this. It's easy. This drug is not, it can lower the seizure threshold, but not associated with the sexual side effects of other antidepressants. This drug can lower the seizure threshold, but it is not associated with the sexual side effects of other antidepressants. You know this already. Come on.
Bupropion.
Exactly. Wellbutrin. Wellbutrin. Your bupropion. Good job. Next. Schizophrenia. So what are these? Let's go back to term 2. You have both positive and negative and cognitive symptoms. Question: what causes the positive symptoms in schizophrenia? What causes the positive symptoms? What dopaminergic pathway in the brain is
The mesolimbic.
Mesolimbic.
increase or decrease activation of the mesolimbic?
Increase.
Increase. Excellent. It's mesolimbic. That's why you have those hallucinations, delusions, your bizarre behavior, disorganized speech. How about the negative symptoms?
Decrease in
Decreased hypoactivity of what?
mesocortical.
Mesocortical. Good job. That's why you have the flat or blunted affect. Anhedonia. What is anhedonia? What is anhedonia?
Loss of interest.
Excellent. Loss of interest. Apathy. Alogia. Lack of interest and socialization. Right? And you can also have some cognitive symptoms. There are three phases: prodromal, psychotic, and residual. Prodromal, you have decline in your functioning that precedes the first psychotic break. Then you have a psychotic break. You have perceptual disturbances, delusions, disordered thoughts, and the residual. Following an episode of active psychosis, you can have some mild hallucinations, social withdrawal, and negative symptoms. How do we diagnose? Again, term 2. Let's go back. 2 or more of the following for at least 1 month: delusions, hallucinations, and disorganized speech. You need to have those: delusions, hallucinations, disorganized speech, and some of the negative symptoms. It must cause significant social, functional deterioration, and symptoms are not due to the effects of a substance or another medical condition. What's a pathophys of schizophrenia? Again, dopamine pathway is affected in schizo. Prefrontal cortical, inadequate dopaminergic activity, responsible for negative symptoms. Mesolimbic, excessive dopaminergic activity, responsible for positive symptoms. The tubero-infundibular pathway is also involved. Why? Antipsychotics block that pathway, causing what? Hyperprolactinemia. You can have gynecomastia, galactorrhea, sexual dysfunction, and menstrual irregularities. Also, antipsychotics block the nigrostriatal pathway, causing Parkinsonism, EPS side effects. You have tremor, rigidity, slurred speech, akathisia, dystonia, and other abnormal movements. Don't forget the neurotransmitters implicated in schizo: elevated serotonin, elevated norepinephrine, decrease in GABA. GABA is the major blank in the brain. It's the major excitatory and inhibitory neurotransmitter in the brain. GABA. GABA, GABA. Excitatory or inhibitory?
Inhibitor.
Inhibitory, excellent. In the brain. Glutamate is the major excitatory neurotransmitter in the brain. Again, schizo, increased serotonin, increased norepinephrine, decrease in GABA, and decrease in glutamate receptors. Let's talk about antipsychotics used to treat psychotic disorders, typical or first generation, right? We sometimes call this one the neuroleptics, right? In the olden days. They affect what receptor? They block the dopamine D2 receptors. And the atypical second generation antipsychotics, they block both the dopamine, the D2, and serotonin 2A receptors. So typical first generation, only dopamine, D2 receptors. Atypical or second generation, D2 and 2A, both dopamine and serotonin. They have a number of actions and some receptor interactions in the brain. Both the typical and atypical high yield, they have similar efficacies in treating the presence of positive psychotic symptoms, so your hallucinations, your delusions, right? Atypical antipsychotics, they are thought to be more effective at treating the negative symptoms, the anhedonia, the alogia, the decrease in interest in socialization, the flat affect. Okay, don't forget that. I have a question again for you guys. So be careful when you prescribe your atypical antipsychotics. Why? Because studies show they have an increased risk of mortality and stroke when you use these agents in the elderly. Okay? Although they are used to treat behavioral symptoms of dementia and delirium, studies have shown that when you give atypical antipsychotics to the elderly, it has an increased risk of mortality and stroke. Just a warning for you, guys. So the choice of which specifics medication to prescribe should be made based on, patient's clinical presentation, past response, and side effect profile. Let's go to the meat of the antipsychotics. Low potency, typical. Lower affinity for dopamine. Remember, potency means what? The action on the receptor itself, not on the level of efficacy, right? Higher incidence, however, of HAM, anti-HAM effects for your low potency typical antipsychotics. They also have lower incidence of EPS. However, if you overdose with this one, you can have QT prolongation and potential for AV block and ventricular tachycardia. So what are the drugs? Right? There's a risk for agranulocytosis also and seizure risk. So what are the drugs? Chlorpromazine. Chlorpromazine, think corneal deposits, right? So it causes like orthostatic hypotension and don't forget high yield blue-gray skin discoloration. Okay, that's your chlorpromazine. Thioridazine, think about the retina. There's an R there, thioridazine, associated with retinitis pigmentosa. Question, can high-potency antipsychotics be given IM? Can you give an agitated or a psychotic patient a high-potency antipsychotic via intramuscular injection? Yes or no? Yes, actually, you can give it. All right. So mid-potency, there's no high yield there. High potency, high yield, very high yield, typical antipsychotics. You have a greater affinity for dopamine receptors, less sedation. However, the greatest risk for EPS. Haldol can be given POIM-IV, lofenazine, trifluoroperazine, pimozide, associated with QT prolongation. I have a question again for you guys. So Haldol and fluphenazine, right? They are available in long-acting intramuscular forms. So when you go to your rotation next year, you can see in the order like the Haldol decanoate, right? So these are very useful in patients. Do you think of what? What kind of patients is useful in taking a Haldol decanoate, a long-acting intramuscular injection? What do you think, guys? They're very useful in patients that's what?
Like acute agitation?
Exactly. What else? If they are not compliant with their medications. If they said, doc, I don't want anything. I don't like to swallow pills. So you give them Haldol and fluphenazine decanoate, right? Your medication non-compliant patient, you can give long-acting intramuscular decanoate. Don't forget also that your risperidone maintenance. What is maintenance? Generic. Aripiprazole and what's Invega in generic? Invega is paliperidone. They have long-acting injectables. However, they are more expensive. Okay. Now, let's look at the side effects then. Side effects. So the positive symptoms again, treated by action in the mesolimbic dopamine pathway. The negative symptoms are thought to occur due to decreased dopamine action in the mesocortical pathway. We talked about the EPS. We talked about increased prolactin. It is caused by dopamine blockade in the tuberoinfundibular area. Now, about the EPS symptoms. Out of these, Parkinsonism, akathisia, dystonia. What's the first thing that you can see in a patient after being given, for example, Haldol? Your high potency, first generation, typical antipsychotic. Out of these three, which one comes first?
Dystonia?
Dystonia. Excellent. What can we give in dystonia? What can we give?
Benztropine.
Excellent. Good job. Benztropine. What's next? After dystonia, what can we see?
Akathisia?
Excellent. Good job. Akathisia. What can we give? It's in there. Read. Beta blockers, or you can give benzodiazepines. Last but Parkinsonism. Next is Parkinsonism. What can we give?
Benzotropine or
Benzotropine, yes, cogentin, of course. Right? Last but not the least is tardive dyskinesia. What can we give for tardive dyskinesia?
I'm sorry, I didn't hear what you said for the last one.
Parkinsonism? Benzotropine. You can give benzotropine for that.
Oh, I thought you said there was a second thing after that. Never mind.
Oh, cogentin. That's what do you call this one? It's not a generic name. It's the brand name. Brand name. Benzotropine is the generic name. The brand name is cogentin. Okay. It's the same.
Thank you.
Yeah. It's the same thing. Sorry, guys. Because in the hospital they use like the brand names. Okay. So next is tardive dyskinesia. Do we have a treatment for tardive dyskinesia? Yes, we have a drug. Tell me the drug. VMAT inhibitors. VMAT.
Valbenzine.
Excellent.
Valbenzine.
Valbenzine. Those are high yield, guys. The one that we just did, they are high yield. Okay. Let's summarize. Dystonia. In the vignette, they're gonna see there's a painful contraction of muscles of the neck, or the head is on one side, the neck is stiff. We call that one torticollis. Or the eyes are up. There's something wrong with the eyes. Oculogyric crisis. Life-threatening. Give benzotropine. Akathisia. The patient seems fidgety. He can't sit still. He's pacing around the room. So you give beta blockers or benzodiazepines. The patient has mask-like facies. He doesn't smile much. He has this cogwheel rigidity. He has a pill rolling tremor. Parkinsonism. Give benzotropine or cogentin. Tardive dyskinesia. Lip smacking, tongue protrusion. We can give valbenazine or the other one, deutetrabenazine, which are your VMAT2 inhibitors. Excellent, guys. Next, wait a minute. What's going on here? Hyperprolactinemia. Right? Is that correct? We talk about tardive dyskinesia. So you can also have hyperprolactinemia, right? Decrease in libido, galactorrhea, gynecomastia. What can we give in someone who has hyperprolactinemia? Come on. What can we give? Hyperprolactinemia, guys.
Bromocriptine.
Bromocriptine. What else? The other one. The other one. It starts with a C. Cabergoline. Okay. Don't forget that one, guys. All right. Also, your anti-HAM effects, antihistamine, you know all of that. We talk about tardive dyskinesia. So, what's the when you go to the wards, right? The treatment of EPS, what's the first thing that you need to do? The initial treatment, you reduce the dose of your antipsychotics, and you administer an anticholinergic agent, right? Or you can use an anti-Parkinsonian medication, such as, this is a viral medication. You can also give this one. Excellent. Your Symetrel. Symetrel is the brand name for your amantadine. Okay, don't forget that. So let's talk about, where is that? Let's talk about NMS, Neuroleptic Malignant Syndrome, very rare, medical emergency. What's the mnemonic? Faltered. However, I want you only to know lead pipe rigidity for NMS and increased creatinine phosphokinase. That's it. It is NMS. Rhabdomyolysis also. Don't forget that. What is the first atypical antipsychotic that is less likely to cause tardive dyskinesia?
Clozapine.
Again, please.
Clozapine.
Excellent. Good job. Clozaril is the first atypical antipsychotic that is less likely to cause your tardive dyskinesia. So what's the treatment for NMS? You just discontinue the medication. You can give bromocriptine. You can give amantadine. This is not an allergic reaction, okay? You could have elevated liver enzymes and jaundice. You have ophthalmologic problems, right? Dermatologic problems, and some seizures. Don't forget the risk for developing tardive dyskinesia in someone who's being treated with a typical antipsychotic, so Haldol or fluphenazine, is only 5%. Okay, it's less. So the risk is very, very small. Let's talk about the atypicals. They block both high-yield dopamine and serotonin receptors. D2, right? S2. They are less likely to cause EPS, TDs, or NMS, high yield. They are maybe more effective in treating negative symptoms of schizophrenia, high yield. Examples: clozapine. This is the poster girl for a typical antipsychotic. Clozapine, less likely to cause TD, more efficacious, high yield, used in treatment refractory schizophrenia. You give all of the drugs for schizophrenia, nothing still works. The last drug that you give is clozapine, clozaril. Question: it doesn't work. What's next? You give everything, and then you have clozapine because it's used in treatment refractory schizophrenia. It still doesn't work. What's the last resort, doctors, that you're gonna do?
The brain stimulation.
Brain, or what do we call this one?
ECT.
Electric shock therapy.
ECT, excellent. Electroshock therapy. Always last resort. If it doesn't work, if the medication doesn't work, give ECT. It works. Clozapine has the smallest risk of myocarditis. However, what's the high yield here? Agranulocytosis. So doctors, you need to check the neutrophil counts, okay? Also some seizures, right? Another high yield point for clozapine. This is the only antipsychotic shown to decrease the risk of suicide, okay? In terms of statistics, epidemiology, like 30% of your patient with treatment-resistant psychosis, they will typically respond to clozapine, 30%. Right. So Haldol has an increased risk of extrapyramidal side effect, such as dystonia and tardive dyskinesia. However, Haldol does not typically lead to agranulocytosis. Haldol rarely gives you agranulocytosis, only clozapine. Okay, clozapine equals agranulocytosis, although 1% incidence. Okay. It's not bad, but still. Next, risperidone. High yield increase in prolactin, orthostatic hypotension and reflex tachycardia. Quetiapine, Seroquel, less likely EPS. Side effects: sedation and orthostatic hypotension. Olanzapine, side effect: weight gain. Ziprasidone, high yield. This is the only atypical antipsychotics associated with QT prolongation. Ziprasidone. This is Geodon, right? And another high yield point: it must be taken with food. If not, there's a 50% reduction in absorption without a meal. So tell your patient to eat this, to eat food and then get the drug. Okay, swallow the drug afterwards. Another high yield, aripiprazole. This is the only atypical second generation antipsychotic that has a unique mechanism. Why? It has a partial D2 agonist. In the vignette, when they say partial D2 agonist, think about Abilify, think about aripiprazole. Also, we have a newer drugs like your paliperidone and Vega, which is, I've seen this one in the wards during my clinical, and lurasidone, Latuda. Must be taken with food, used in bipolar depression. So you can give lurasidone in bipolar depression. So guys, could you give me drugs that have FDA approval for treatment of mania? drugs that have FDA approval, okay, for treatment of mania.
Like lithium?
Go. Lithium, okay. Now give me the atypical or second generation antipsychotics. Let me qualify that question.
Clozapine and olanzapine.
Excellent, excellent. What else? Geo. Okay, all right. Maybe it's just me, but it's when you go to clinicals. Quetiapine. What's the other one? Olanzapine. Aripiprazole. Risperidone. Oh God, what's the other one? Let me check the list. Arsenapine can also be used, your Safris, and ziprasidone, geodone. Those are FDA approved for treatment of mania. Now, high yield point for your atypicals. What's the side effect? Metabolic syndrome. So weight gain. The patient's BMI a couple of months ago is 20. Now he's 38. Oh, that's metabolic syndrome. Weight gain, hyperlipidemia, and hyperglycemia. What can we give if they develop weight gain? What's the first drug that you give in a type 2 diabetic that we can give here for metabolic syndrome? It can cause lactic acidosis.
Metformin.
Excellent. Good job. You can give metformin. And again, another high yield QT prolongation, ziprasidone, right? Don't forget that drug. So, question for you guys. Your patient is on clozapine. What should you do as a doctor? What should you monitor?
CBC.
Excellent. So check it every 6 months, right? From the CBC, what do we really need to check?
I think it's the neutrophils that are most
Absolute neutrophil counts because of the risk of your agranulocytosis. With time, you decrease the frequency of the blood draws. Next, let's go to bipolar. Bipolar 1 versus bipolar 2. Tell me the differentiating factor. Which one has hypomanic episodes? Which one has hypomania?
Type 1. Oh, wait, type 2.
Hypomania. Careful, guys.
Type 2.
Type 2. Which one has mania? The manic episode. Bipolar 1 has your manic episode, right? In terms of epidemiology, laughter prevalence of 1%. Yeah. Women and men are equally affected. So it's an equal opportunity offender. No ethnic differences. Frequently misdiagnosed, okay? And thereby inappropriately or inadequately treated. In terms of etiology, it has a high concordance rate, guys. So if you have a twin, a monozygotic twin that has bipolar, you are more likely to get like 40 to 70% more likely for you to have bipolar also. And for dizygotic twins, 5 to 25%. Bipolar 1 has the highest genetic link of all your major psychiatric disorders. That's high yield. And remember, there's a chance for relapse. They can go back to mania. 90% of individuals after one manic episode will have a repeat episode within 5 years. This is most commonly seen. I've seen this during my psych rotation. Bipolar 2, hypomania. What's the difference between mania and hypomania? What's the difference between mania and hypomania?
The ability to function.
Excellent. So hypomania, you can still function. You can still go to work and plan world domination at the same time. Can you imagine? Now, let's talk about mood stabilizers. Mood stabilizers used to treat acute mania and help prevent relapses of your manic episode. Less commonly may be used for augmentation of antidepressants, potentiation of antipsychotics, treatment of aggression, And enhancement of abstinence in treatment of alcoholism. So I have a question again for you guys. Which class of drugs can be used as an adjunct to mood stabilizers early in the course of a manic episode?
Anticonvulsants, like valproate.
Careful.
Oh, those are not adjuncts. Never mind.
Let me repeat the question. What class of drugs may be used as adjunct to mood stabilizers early in the course of a manic episode? Just give me the class of drug. I don't want a specific drug. Excellent. Good job. Whoever said it. Antipsychotics. It can be used as an adjunct. Another question. A class of drugs that are often prescribed as monotherapy, highlight monotherapy, in the acute or maintenance treatment of bipolar disorder. What class of drugs are often prescribed as monotherapy?
Yeah, that's anticonvulsants.
Come again, please?
Anticonvulsants like valproate or carbamazepine can be used.
Careful. Monotherapy. You don't combine it this time. Careful. You don't combine it at this time.
Lamotrigine.
Atypical antipsychotics. I'm looking for atypical antipsychotics. Okay, so maybe this is when you go to on your rotations. So atypical antipsychotics, they are often prescribed as monotherapy in acute or maintenance treatment of your bipolar disorder. And they love this drug, lithium. Lithium is the drug of choice in acute mania and as prophylaxis for both manic and depressive episodes in bipolar and schizoaffective disorders. Lithium is the only mood stabilizer shown to do what? Lithium is the only mood stabilizer shown to do what, guys? Anyone? Where's my IEA people? Where's my people? Lithium is the only mood stabilizer shown to what? Where's my honors college? It is the only mood stabilizer that is shown to. Hello?
Are we looking for like an adverse effect or something positive?
It is shown to decrease what? Come on, you know this. You know this, guys. It is the only mood stabilizer shown to decrease
Sexual function.
No.
Suicide.
Okay, guys. If you have bipolar disorder, you're commonly at risk of doing what?
Committing suicide.
What? Suicide, exactly. And what drug is the only, underline that, only mood stabilizer shown to decrease suicidality? It's lithium. Okay, that's high yield. Don't forget that, please. All right, good job. Now, lithium is metabolized by the kidney. So if your patient has acute kidney injury or CKD, chronic kidney disease, you need to adjust the dose. What else do you need to monitor when prescribing lithium, high yield? What else do we need to monitor? And give me the reasons, doctors. Why do we need to monitor things?
Thyroid function.
Why?
Because it can cause hypothyroidism.
Excellent. What else?
Also, like renal function, serum creatinine, because it can cause nephrogenic diabetes insipidus.
Nephrogenic diabetes insipidus. What kind of urine do you have? A nephrogenic DI? Dilute or concentrate?
Dilute urine.
How can we differentiate this one with the central DI? What's the test that you need to do?
Water deprivation test.
Exactly. Or you can also do a vasopressin test. I want to do a vasopressin test. How can we differentiate it then? If we give exogenous vasopressin, what happens?
So if it
Urine.
is central, giving me vasopressin will help, whereas if it's nephrogenic, vasopressin will not help.
Exactly. Good job, guys. So when prescribing lithium, it is important, doctors, you monitor the lithium levels, creatinine, thyroid function test. The onset of action, it takes 5 to 7 days. Okay, let's synthesize. You're talking about drawing blood and blood levels. Blood levels are useful for monitoring lithium. What else? Give me other drugs that you need to monitor the blood levels, aside from lithium. Go. You keep on talking about anticonvulsants. Now is the time to bring it up.
Clozapine.
Excellent. Another one? Someone before about, they're talking about anticonvulsants. Someone said it before.
Yeah, valproate and
Excellent. Valproic acid. There's another one.
and carbamazepine.
Excellent. Good job, guys. So blood levels, okay, useful for lithium, valproic acid, carbamazepine, and your clozapine. So guys, the major drawback, however, of lithium, it's, of course, the high incidence of your side effects, very narrow therapeutic index. So you check the lithium level in your patient. Oops, it's 5.0. What are you going to do? Oopsie, we made a boo-boo. What are you going to do? The lethal dose is 2.0. You check. Oops, it's more than 5. Oh God, I made a mistake.
You need to give a diuretic.
Careful. If you diurese it, you might induce more metabolic disorders, right? Careful. Oh God, what should I do? Did you discuss this in class or not yet?
Do you give things that reduce the GFR or like renal perfusion?
You need to remove lithium from the body, right? So you can do last resort, or the first one that you need to do actually is, if it's like more than 5, is to do dialysis. You need to do dialysis, either hemodialysis or peritoneal dialysis, if it's more than 5. Okay, good. Side effects of lithiums: AMS, coarse tremors, convulsions, right? If the patient is on lithium, you need to be careful, doctors, in prescribing what? Think about the kidney function.
NSAIDs and ACE inhibitors.
Excellent. Good job. Yes. Careful in prescribing ibuprofen or your other NSAIDs. Why? Why?
Because NSAIDs would reduce the perfusion to the kidney, and then ACE inhibitors reduce the GFR.
Prostaglandin. Okay, excellent. Prostaglandin dilates what arteriole? Prostaglandin dilates
afferent.
Afferent arteriole. Okay, and angiotensin 2 constricts what? The efferent arteriole. Okay, don't forget that, so that you can maintain your GFR. As I've said before, fine tremor, side effects of lithium, nephrogenic DI, sedation, hypothyroidism, ECG changes, benign leukocytosis, and lithium can cause Ebstein's anomaly. What is this? Can someone explain this to me? Ebstein's anomaly. What is this?
Where you have a malformed like tricuspid valve, so then the right atria is larger than it should be.
Exactly. So you have the actually, so your tricuspid valve, it goes to the right ventricle, right? So you have atrialization of your ventricle. So what if I have atrialization of my ventricle? It can lead to what kind of heart failure? Right-sided or left-sided heart failure?
Right.
Excellent. Right-sided heart failure. Signs and symptoms? Bonus points? of right-sided heart failure? Anasarca, of
Edema.
course.
Pulmonary hypertension.
Of course. What else? Right is generalized edema. Left is pulmonary edema. You're gonna learn more in the wards about, HRPEF and HP, right? If the reduced ejection fraction and the regular ejection fraction. All right, now let's summarize, okay? Lithium is very high yield. All right, so I have a question again for you. Tell me the factors that increases lithium levels. Whether it's drug, whether it's something, tell me the factors, the disease that increases your lithium levels, high yield. We talked about NSAIDs, right? So be careful.
Thiazide.
Thiazide diuretics, common side effect of thiazide. What is the most common side effect of your thiazides?
Hypercalcemia.
Hyperglycemia, hyperuricemia, you remember the hypergluc? Hyperlipidemia, okay? Hypercalcemia, don't forget that one. What else? So NSAIDs, thiazide diuretics, what other factors can increase your lithium levels?
ACE inhibitor.
In the desert. I'm in the desert for a week. Help. Dehydration. Excellent. Commonly prescribed now in the elderly, 81 milligrams. You need to take this, Mrs. Johnson. It's for your heart. Aspirin. Aspirin can increase your lithium levels. I'm on a diet. I don't want to eat salty foods. Salt deprivation can increase your lithium levels. Oh, I want to go to the gym. I want to sweat a lot. Sweating or can increase lithium levels. Why? You are losing salt. Or if your patient has chronic kidney disease, impaired renal function, it can increase lithium levels. Summarize, factors that increase lithium levels: impaired renal function, sweating, salt deprivation, dehydration, thiazide, diuretics, aspirin, and NSAIDs. Move on. Anticonvulsants, carbamazepine, useful in treating mania with mixed features and rapid cycling. MOA, high yield, blocks sodium channels, thereby inhibiting your action potential. Onset of action, 5 to 7 days. CBC LFTs must be obtained before initiating treatment and regularly monitored during treatment. Side effect of carbamazepine, the most common side effect, GI and CNS, and a possible skin rash, Stevens-Johnson syndrome. Question, differentiate SJS versus toxic epidermal necrolysis, or TEN. What's the difference?
It's 10 if it's greater than 30% of the body surface area.
What is that? If greater than 30%, what is it? Is it SJS or TEN?
TEN if it's greater than.
Yep. How about SJS? Less than 10%. And if it's 10 to 30% of the BSA, it's mixed. Okay, don't forget that. That's high yield. You can also have leukopenia, hyponatremia, aplastic anemia, thrombocytopenia, and agranulocytosis. Elevation of liver enzymes causing hepatitis. You have teratogenic effects when used during pregnancy. Significant drug interactions and some toxicity. I have a question again for you guys. I forgot to ask this one. So in lithium, it can cause benign leukocytosis, right? Is that beneficial if we have leukocytosis? Yes, it can be advantageous when combined with other medications that decrease the WBC, which is, we've discussed about this, which is what drug?
Clozapine.
Clozapine, excellent. So I wanted to make this connection, right? That the side effect of leukocytosis with lithium, it can be advantageous when you combine it with other medications that decreases the WBC count, such as clozapine. Okay, just put that in your mind when you go to your clinical rotations. Again, next, valproic acid, acute mania. All of your anticonvulsants are hepatotoxic. So you need to check LFTs and CBC. You should be checked drug levels after 4 to 5 days. Contraindicated in pregnancy. Why? Neural tube defects. Next, lamotrigine, effective for bipolar depression. Most serious side effect is high-yield Stevens-Johnson syndrome, although 0.1% of patients experience that. Most likely in the first 2 to 8 weeks. How are we going to minimize this? Go slow. Start slow, right? And go low. Start with low doses and you increase slowly. Don't forget that valproate will increase the lamotrigine levels and vice versa. The lamotrigine will decrease the valproate levels. Oxcarbazepine, high yield, there's hyponatremia. For gabapentin, neuropathic pain, that's high yield. Pregabalin, Lyrica. GAD, second line, and fibromyalgia, high yield. Topiramate, high yield. Side effect is weight loss. Okay. However, be careful because the most limiting side effect of Topamax is cognitive slowing. Okay. So for this one, I want you to know carbamazepine, valproic acid, lamotrigine, gabapentin, and topiramate. I think those are the high yield drugs. Side effects, of course, GI, weight gain, alopecia, pancreatitis, and hepatotoxicity. Question, guys. Since we're talking about hepatos, hopefully you're not getting sick and tired of my questions, right? You're not leaving the chat, right? So question, guys. If your patient is a chronic alcoholic or it has a liver disease, right? We can use benzos that are not metabolized by the liver. Now give me the benzodiazepines that are not metabolized by the liver. High yield.
Oxazepam and razepam.
So LOT, right? Lorazepam, oxazepam, temazepam. All right. Good job. Don't forget also your anticonvulsants. They are teratogenic. Don't give to mom because of neural tube defects. Next, we're going to talk about anxiolytics or hypnotics. What is anxiety? It is defined as excessive, irrational, out of proportion to trigger or without an identifiable trigger. You can read all about that. Major neurotransmitter implicated, norepi, you have serotonin and GABA. This is the most common form of psychopathology. You can see this one in clinics from children up until like elderly. They can have this one. However, gender, in terms of gender, more frequently seen in women compared to men, 2-to-1 ratio. Treatment based on whether it's moderate or milder presentations. You can read the signs and symptoms of anxiety. There are some medications and substances that cause anxiety. You can read that: alcohol, sedatives, cannabis, hallucinogens, caffeine, tobacco, and opioids. And also medical conditions that cause anxiety. You can read all about that. Now, let's go to anxiolytics. These are your benzodiazepines, barbiturates, and buspirone. Doctor, I'm taking these drugs, benzos. Can I drink alcohol? I really want to go to the bar and drink alcohol. Can I go to the bar and drink alcohol? Yes or no?
No,
Why, doctor? Tell me.
it'll exacerbate the effects.
And
binds to the same.
What's the major cause of death when benzos are mixed with alcohol?
Respiratory depression.
Boom. Excellent. Respiratory depression. Good job, guys. Okay. Benzodiazepines, high yield. They potentiate the effects of your GABA. They also reduce anxiety and can treat akathisia, one of your EPS. However, many patients, they become physically dependent on these medications, and they require increasing amounts for the same clinical effect. Don't forget of tolerance. It has a high potential for abuse. Okay? So you need to know the long-acting ones. Diazepam, Valium, rapid onset, detox for alcohol, high yield, effective for muscle, spasm, clonazepam, clonopine. Avoid with renal dysfunction. Why? Because of the longer half-life. Intermediate acting, alprazolam, your Xanax, shorter onset of action, increased risk of euphoria, and high abuse potential. High yield. Don't forget your LOT, L-O-T. They are not metabolized by the liver. Midazolam, Versed, it's high yield. It has the very short half-life. Out of all your benzo, this has the shortest half-life, your midazolam, primarily used in medical and surgical settings. Question, benzo overdose, what can you give?
Fumazanil.
Fumazanil, excellent. So you induce withdrawal then, right? But be careful, don't do it quickly because it's life-threatening. Side effects, you can read that one. Let's talk about the non-benzodiazepine hypnotics. Zolpidem, your Zaleplon, or your Ezopiklon, my God. Ambien, Sonata, Lunesta, right? So they work by selectively binding to your omega-1 receptor, high yield, on the what? GABA-A receptor, which is responsible for sedation, can be used for short-term treatment of insomnia. Compared to your benzos, since they are non-benzo, they have less tolerance and dependence. Zaleplon has the shorter half-life than Zolpidem, which has a shorter half-life than Ezopiklon, okay? So some people reports like anterograde, amnesia, hallucinations, and parasomnias, right? Like Mrs. Macbeth, sleepwalking. Can you imagine that? And GI side effects. They limit their tolerability. Of course, diphenhydramine, Benadryl, side effects, sedation, dry mouth, and Ramelteon, selective melatonin agonist, high yield, no tolerance or dependence. So no Zolpidem, diphenhydramine, and Ramelteon for that. Next, buspirone, mechanism of action, partial agonist at 5-HT1A receptor, slower onset than your benzos. It does not potentiate the CNS depression of alcohol and low potential for abuse. You should also know hydroxyzine and antihistamine. All right, side effects, of course, antihistaminergic. Barbiturates, rarely used now, right, because of lethality of overdose. One of the most beautiful women in the world, Marilyn Monroe, she died because of overdose. Barbiturates and alcohol. Propranolol, beta blocker, useful in treating the autonomic effects of your panic attacks. It can also be used to treat akathisia, which is a side effect of antipsychotics. Please know those. Buspirone, hydroxyzine, barbiturates, propranolol. They are high yield. Now, let's go to psychostimulants. ADHD, you need to have 6 inattentive symptoms and 6 hyperactivity symptoms. Question. The kid is, he fails to give close attention to details in the school. He has difficulty sustaining attention in school. He has 6 inattentive symptoms in school, but he's okay at home. Is that ADHD? Yes or no? he only has inattentive symptoms and hyperactivity symptoms in one setting. Is that ADHD?
No.
No.
Why? What is how many settings should it be if it's ADHD?
2 or more.
2 or more, exactly. At least 2 settings, home and school. Excellent. You know, yada yada yada. You can read all of that. So, psychostimulants. What do we give? High yield, dextroamphetamine and amphetamines. This is your Schedule 2, guys. Okay. So high potential for abuse. You need to monitor blood pressure, weight loss, insomnia. Next, methylphenidate, Ritalin. I know. CNS stimulants, Schedule 2, high yield. Watch for leukopenia or anemia. Therefore, check blood pressure and CBC. The newer ones is atomoxetine. The mother says, I don't want my child to be dependent on a psychostimulant. I don't want amphetamines or methylphenidate. As a doctor, you can give Strattera, atomoxetine. It's the same thing. Less appetite suppression and insomnia. However, it is not classified as a controlled substance. Less abuse potential, rare liver toxicity. And you can have modafinil, which is used in narcolepsy. Narcolepsy has what kind of hallucinations? Hypnagogic or hypnopompic? Narcolepsy. Are you there? Hypnagogic or hypnopompic, guys? You could do hypnagogic or that one. Alzheimer's disease, most common etiology of your major dementias. Gradual progressive decline. It can affect memory, learning, language, some personality changes. So don't forget, for this one, Alzheimer's, you have accumulation of your beta amyloid plaques and intraneuronal tau protein tangles. So the beta amyloid plaques are extraneuronal, outside the neuron, and the thing that's inside the neuron are your tau protein tangles. So what do we give? What can we give? Acetylcholinesterase inhibitors, donepezil, galantamine, rivastigmine. So donepezil, some GI side effects, same as in galantamine and rivastigmine, right? So don't forget, the Alzheimer's medications, your donepezil and rivastigmine, they work by reversible inhibition of your acetylcholine esterase, okay? Don't forget that. You can also give memantine or Namenda. This is your use in moderate to severe neurocognitive disorders. It should be used with acetylcholinesterase inhibitors. Let's talk about Parkinson's disease. You can have resting tremor, bradykinesia, postural instability. You can need all of that. Cognitive decline appears after the onset of your motor symptoms. What's the treatment? Carbidopa, levodopa, or your dopamine agonist. High-yield quetiapine and clozapine, they are the preferred medications for the treatment of your psychotic symptoms that are not responsive to dose reduction. So if someone has PD and you give carbidopa, levodopa, your dopamine agonist, right, and they develop psychotic symptoms, you try to reduce the dose, it doesn't work, so you can give quetiapine and clozapine. We're good so far?
Yes.
Yes? Okay. You want me to continue? It's 11:48.
Yes.
Or do you need a break? We're nearing the 2-hour mark. Continue? Okay. We're going to take
Yes.
after pharmacology, we can take a break and then we can do patho for today if you want. And then we can do infectious disease either tomorrow or whatever. Okay?
Okay.
All right. And I want to do it today because tomorrow is Valentine's Day. But let's see. Substance use disorders, right? Okay, guys, you need to know the withdrawal symptoms, basically. That's it. So how do we test? Alcohol, cocaine, amphetamines, PCP, urine, drug screen. Right? Sedative hypnotics, you can read that, opioids, and marijuana. All right? Alcohol is GABA, right? It activates your GABA, dopamine, and serotonin. It inhibits your glutamate receptors. It is metabolized in the following manner: alcohol to acetaldehyde via your alcohol dehydrogenase, acetaldehyde to acetic acid via your aldehyde dehydrogenase. So the clinical presentation, you can read that. Treatment: monitor airway, breathing, circulation always. Give thiamine before giving the dextrose. Why? Why should we give thiamine first?
So you don't exacerbate the symptoms. Because
Exactly. And thiamine is used in gluconeogenesis, right? So you need to give thiamine first. You need to give a cofactor. You need to give the cofactor first in your biochemical reactions before giving glucose. Because if you give glucose first, it will gonna use up the remaining thiamine in the blood, and you don't want that. Your patient will gonna have a thiamine deficiency. So you give a bolus of thiamine first before you give your dextrose. Good job. Now naloxone may be necessary to reverse the effects, okay? If they ingest some opioids. Clinical presentation, you need to know alcohol withdrawal syndrome, insomnia, anxiety. They're gonna put in the vignette, oh, something's crawling on my skin, bugs. I see bugs crawling on my skin. They keep on scratching. They have these excoriations. Think alcohol withdrawal. They typically begin 6 to 24 hours after the patient's last drink. You need to be careful. Why? Because of delirium tremens. It begins high yield 48 to 96 hours after the last drink. Okay, so the first thing that you can see, you can have visual hallucinations. You can see the scratching, bugs crawling on my skin. If you didn't catch that one, you can now have delirium tremors now. Okay. So in addition to delirium, they have hallucinations, gross tremor, and autonomic instability. It's a medical emergency. What's the treatment for delirium tremens? What's the treatment? Benzodiazepines. There we go, benzodiazepines, antipsychotics, and all the others. So when patient comes in the emergency room, you're gonna see the CWA scale. This is the to monitor like withdrawal signs and symptoms. When you go to your ED rotation, you can see this scale. Check also signs of hepatic failure like ascites, jaundice, and caput medusa and coagulopathy. Cocaine, dopamine, of course, increase in dopamine, epinephrine, norepinephrine in the synaptic cleft. They feel euphoric, heightened self-esteem, right? It's very dangerous. Why? Overdosing can cause respiratory depression. How do you manage? If they have agitation, anxiety, benzos, you can also give antipsychotics if they have psychosis. And of course, symptomatic support. That means they block reuptake and release of dopamine and norepi. How do they present? Hyperthermic, dehydration, rhabdomyo, and renal failure. Treatment: rehydrate, correct your electrolyte balance, and treat hyperthermia. PCP, angel dust, visual, like no. For PCP, they're very, very violent. Okay, they're very violent. Nystagmus also, not only rotary but horizontal or vertical for PCP. In the vignette, aside from the violent behavior, they're gonna put in nystagmus. So monitor vitals. You can use benzo to treat agitation, or you can use antipsychotics to control the severe agitation. Sedative hypnotics, if they overdose, you can read that one. Don't combine them with alcohol or they're gonna go into respiratory depression. Treatment: maintain airway breathing. For barbiturates only, alkalinize the urine, high yield. For benzos, flumazenil in overdose. Withdrawal can be life-threatening. Opioids, in the vignette, think constricted pupils. Respiratory rate is low. So think about opioid intoxication. What can we give for opioid? Naloxone, right? You can give that one. So these are just the pharmacological treatment of your opioid use disorders. You can read that, the pros and the cons. Hallucinogens, LSD, visual hallucinations for intoxication. What's the treatment? Monitor for dangerous behavior. If there is a presence of psychosis, you can give antipsychotics. And in withdrawal, right, you may experience flashbacks later in life. No withdrawal symptoms is produced, but if they use LSD for long term, they may experience flashback later in life. Marijuana, of course, it's getting legal everywhere, even in New York State. Marijuana, most commonly used illicit substance in the world. It has some efficacy in treating nausea and vomiting in chemo patients. Right? So always look in the vignette for intoxication, conjunctival injection. It's just a fancy term of saying red eyes. Okay, if there is conjunctival injection, red eyes, it is marijuana intoxication. What's the treatment? Supportive. If there's a withdrawal, what can we give? Supportive treatment. Inhalants, like solvents, they inhale glue, like pain thinners or fuels. Intoxication, you can read that, some perceptual disturbances. What can we give? Always treat airway, breathing, circulation. They may need oxygen, right? If you need to identify the solvent being used, because it may require, for example, chelation therapy. Withdrawal does not usually occur, but sometimes they can have sleep disturbances, anxiety, depression, nausea, vomiting, and craving. Nicotine, you need to know the withdrawal symptoms of nicotine. Intense craving, dysphoria, anxiety, increase in appetite, and weight gain. How can we treat someone who has nicotine dependence? Chantix, bupropion, nicotine replacement therapy. Also, counseling is very important. It can be a part of every treatment. And relapse is very common. Caffeine, of course, the most commonly used psychoactive substance in the US. Mechanism of action of caffeine, high yield. It increases the cyclic adenosine monophosphate. It is an adenosine antagonist, which stimulates the release of excitatory neurotransmitters. So if you drink 2 cups of coffee a day, that's 250 milligrams, you can have the following symptoms there. If it's 10 grams, death may occur, secondary to seizures and respiratory failure. Treatment is supportive and symptomatic. There's a withdrawal, headache, of course, is there. It usually resolves within 1.5 weeks. This is just a summary of medications that may cause psychiatric symptoms. All right, guys, it's 12 o'clock. Do you want a break before we move on to the antimicrobials and the rest of pharmacology?
Yes, please.
Yep. How many minutes do you think? 30-minute break?
As many as
12:30. We're gonna come back 12:30.
Okay.
Same link, right?
Yes.
Do you like the way that I proctor this review, like the questions that I asked? Do you want me to continue?
Yes.
yes, please.
Okay. All right.
You do you, Nick.
Okay, I know. All right, guys. See you in 30 minutes. 12:30. All right. Same link. Click on the same link. Thank you.
Okay. Thank you.
Have a good lunch.
Thank you.